Welcome to the NCCN Global Policy Webinar, Patient Engagement Driving Access to Quality Cancer Care Globally. Today's session will focus on patient engagement to impact cancer care policy. My name is Katie Winkworth-Presnor, and I'm the Manager of Global Policy and Strategic Alliances at the National Comprehensive Cancer Network. This is the last webinar as part of a series of 3 webinars focusing on global cancer care policy and advocacy. NCCN is a not-for-profit alliance of 31 leading academic cancer centers dedicated to improving and facilitating quality, effective, efficient, and accessible cancer care. Through the leadership and expertise of clinical professionals at NCCN member institutions, NCCN develops resources that present valuable information to numerous stakeholders in the healthcare delivery system. NCCN guidelines and clinical content is utilized throughout the world. Of our 1.4 million registered users on our website, nearly half are located outside of the United States. This heat map shows the distribution of registered users, with users located in nearly every country of the world. NCCN appreciates and recognizes the supporters and sponsors for this webinar series. Without your support, this webinar series would not be possible. Today's program will focus on best practices surrounding patient advocacy efforts to influence and shape policy decision-making regarding access to cancer care globally. The program will begin with a presentation from Dr. Carrie Adams on the role of advocacy in cancer control planning and implementation. Next, we will hear from Ms. Antonella Cardone, who will discuss why patients should be involved with health technology assessment decision-making. Finally, we will host a live panel discussion that will focus on strategies for patient advocacy efforts to influence and shape policy decision-making. Our moderator for today's webinar is Dr. Robert Carlson. Dr. Carlson is Chief Executive Officer at NCCN. At this time, allow me to introduce our 2 keynote speakers. Dr. Carrie Adams is the Chief Executive Officer of the Union for International Cancer Control. UICC unites the cancer community to reduce the global cancer burden, promote greater equity, and integrate cancer control into the World Health and Development Agenda. Dr. Adams has a Bachelor of Science honors degree in economics, computing, and statistics, and a master's degree with distinction in business administration. He is a Harvard Business School alumni and has received 2 honorary doctorates for international relations and health. We will then hear from Ms. Antonella Cardone, Director of the European Cancer Patient Coalition, which is the largest cancer patient umbrella organization in Europe, with over 450 members from 46 countries. She has over 20 years of international advocacy experience in the health, social, and employment sectors. Prior to her role with ECPC, Antonella was Executive Director of the Fit for Work Global Alliance. We are thrilled that Dr. Adams and Ms. Cardone are here today to share their expertise. Their presentations have been pre-recorded, but we welcome your questions and engagements throughout the program.
Thank you very much for that introduction. It's a pleasure to be with you today. And in the next 20 minutes or so, my job will be to cover the role of advocacy in cancer control planning and also implementation. And I'd like to give you a trip in memory lane over the last 10 years on what's happened in cancer control globally and what role organizations like myself, UIC, and others have played in getting those achievements, but also converting it into national action and to improve cancer control around the world. This is what I intend to cover. So I will do very briefly talk about UICC. I would encourage you to go to our website at www.uicc.org. I'll talk about advocacy, what cancer control is to make sure that we're working from the same basis. And I'll talk about World Cancer Declaration and how that has guided us in the global advocacy that myself and others, including Eduardo Kazap, who's on the panel with me later, how that's guided us over the last 10, 15 years. I'll talk about some successes that have been achieved and give you insight on where advocacy played a role to make those achievements happen. And then I'll dig into some great examples of advocacy from the Norwegian Cancer Society, Nepal, and also New South Wales and Australia. And finally, I'll leave you with some personal thoughts on what great advocacy looks like and point you in the direction of some toolkits that you may wish to use if you want to follow up on any of this at all. So let's start with UICC, Union for International Cancer Control. It's been around since 1933, but we're a team of 44 based in Geneva, and we're there because that's where the WHO is, and that's where a lot of the global health organizations are based. We're just over 1,200 members in 172 countries, many of them in North America, but also in many parts of the world, and particularly low middle-income countries where there are lots of organizations that want to benefit from being part of an international organization. We enjoy recognition from the UN agencies like the World Health Organization and others, and we have 58 partners who contribute to our work and our thinking, but also help us implement our business plan around the world. One thing which is quite unique about UICC is that we've been the founders of many different organizations, and we've done these because we've filled gaps in the health community environment, and they pursue things which are very important to cancer control. But we've launched them as separate organizations, and they've been more effective as a result of that, rather than staying within the UICC team. This is a breakdown of the membership. As you've seen, we've grown quite quickly since 2010. And we draw our support and our members from all different types of organizations, from health ministries, large cancer treatment centers, professional associations, and patient groups, and cancer hospitals as well. And we're a multiple award-winning organization for the work that we've done engaging our members and integrating them into the global work that we do on their behalf. So let's start off with a simple question. What is advocacy? I've taken this slide, is from our website. And we genuinely believe that it's a strategic process. It's something that needs to be planned out over a longer period of time. And the target of much of our advocacy is governments and the key stakeholders who impact the thinking of politicians and governments around the world, and the United Nations as well. We believe that advocacy should be evidence-based. We should base our call to action, what we want to achieve, based on scientific evidence. It runs through the very spine of what UIC has done for many, many years. And it all starts with a well thought out plan, and I'll cover some of the aspects of that plan later, which leads to good planning, good execution, and then follow through on the achievements that we are able to get at a global or regional or national level. And I will stress that there is no correct way to perform advocacy. Every organization has its own flavor of getting things achieved. And I'll bring that to life later when I talk about the national approaches to getting change at a national level. Also important to recognize that the Union for International Cancer Control is a balanced organization across the full cancer control continuum. So we're advocating in the space of prevention on tobacco control, for example. We advocate on the availability of screening and vaccinations. We advocate on improved treatment and access to medicines and pricing. And we advocate on the availability of palliative care. So we have a full range of initiatives under those areas, which together means that we should improve cancer control in the longer term. Now, a guiding light for our work on advocacy has been to know what we want. And there's nothing more frustrating for a person receiving the information from an advocate when they say, well, what exactly do you want? And they say, well, we just want it to be better. This doesn't work in global advocacy. You need to be clear about your asks. And in 2009, we developed for the first time the World Cancer Declaration, which was refreshed in 2013 and sets out quite clearly what UIC and its members expect to be happening globally, but also at a national level. So it's quite cleverly written. It can be applied to a country, even a region, or globally. And these 9 target areas: improving health systems, improving data through better registries, reducing risk factors like tobacco use and alcohol, etc., improving the availability of vaccinations, stigma reduction, screening and early detection, access to diagnostics and treatment, availability of pain control and distress management, and improved healthcare education. And the numbers involved in oncology are critical components of that cancer control spectrum. We need movement in all of those elements. We can't just focus in one area. Now, with that in mind, having a target and ambition, a lot of the work that UIC has done has been about making things happen in the global environment to create the global environment, the global framework, in order for national action to take place. That's what my role is, and that's why we're based in Geneva. So if we look at this continuum going through from 2011, what's important is that orange line was going back to 2000 and 2001. There would be nothing in there for the first decade of the year, which really created the global imperative to address cancer and the non-communicable diseases. There was nothing. The United Nations had only held one high-level meeting on a health issue before 2011, and that was on HIV/AIDS in the year 2000. But it was a barren year, a barren decade during the Millennium Development Goals for cancer and the NCDs. And on this one page, you can see how much has been achieved in putting cancer and the NCDs on the global health agenda. 3 high-level meetings at the UN in New York, a new global action plan for NCDs, targets for 2025, integration into the Sustainable Development Goals, improvements at the World Health Organization on the list of essential medicines, a new list on essential technologies, a World Health Assembly cancer resolution, one on palliative care and pain relief, and only last year, not captured on this sheet, but I'll cover it later, a new plan and action, a call to action on the elimination of cervical cancer over the next decades. Critical to all of our work was to achieve a World Health Assembly resolution on cancer care, cancer treatment, cancer control. And we achieved that in 2017, working with a number of member states based in Geneva, but working with national capitals to say that despite all the work that had been done on NCDs, cancer had peculiarities which need to be reflected in member state commitments. And this document, which is available at the WHO website, also on UIC website, sets out 22 priority actions in line with the World Cancer Declaration, which need to be picked up by all countries around the world if we are to make a dent on the increase in cancer cases in the next 10, 20, 30 years. Pivotal is the availability, the writing, and the implementation of a national cancer control plan. So implied in all of our targets, all of our work, we judge the progress of a country on cancer control on whether they have a national cancer control plan, whether it is good and robust, whether it is implemented, and whether it's funded. And I will cover that in a bit more detail in a moment. So between 2010 and 2020, we've shown progress against that backdrop of international agreements and commitments made by member states or countries around the world. We have seen improvements. We've seen areas where we've seen some aspects of cancer control improve, like smoking prevalence, the availability of vaccines. We've seen some areas where there's been no improvement, like the physical inactivity or obesity, which remains a global challenge for everyone. We've also seen early diagnosis improve around the world and people presenting earlier through awareness campaigns about the signs and symptoms of cancer. There's a bit of a mixed picture globally about diagnosis, treatment, rehabilitation, and palliative care. But I believe that we're making progress in that direction. I think that there are challenges and there's a lot more that can be done. The availability of radiotherapy and surgery and qualified oncologists in low and middle income countries is dire in many countries, but we are making progress. Having said that, COVID-19 put the brakes on last year, and we do believe we have the great cancer catch up. We have a lot of people out there who have not presented in the last 18 months or 15 months or so, and therefore we have a lot of challenges in the next 2 to 3 years to do that catch up. National cancer control plans, as I mentioned, are critical to show that a country is committed to cancer control. And what we've done, we've looked at a number of times in the last 5 years on whether there's been progress in the number of national cancer control plans. As you can see from this sheet that we've got from 2013 to 2017, increased from 66% of countries having a national cancer control plan to 81%. And that's now moving up towards 90%. Now, those cancer control plans are either on their own, standalone, or they're integrated within a broader NCD plan. But nonetheless, we monitor all of these through what we call the International Cancer Control Partnership. And that is where all cancer plans around the world are logged and they are analyzed. And through that partnership, we help countries improve their plans on a year-by-year basis. As I've said, I've covered the strength areas where there's been improvements, but there's still much to be done if we actually get those national cancer control plans, which tend to be run for 5 years or so, to make sure they improve over time. Cervical cancer elimination, a great win last year, started 3 years ago with a discussion with Dr. Tedros, myself and a few others in the cancer community about whether or not we could actually put a viable call to action to eliminate a single cancer for the first time in anyone's life. And now that call has come out in November last year, And we're seeing already mobilization at a national level through advocacy, through UICC members in those countries. So those objectives are clear. We need to put plans together in the context of a national cancer control plan. And WHO and others are putting together lots of support and guidelines and encouragement and reporting to make sure that we embrace the challenge of eliminating a cancer. So that's more at the global level and how we can create the framework or the approach or the culture at global level to say, engaging member states, we've got to do something about cancer. And as I say, you go back 12 years ago, there was nothing, but now there is. So let's look at 3 case studies. And I've drawn these from submissions that we had at UIC for an award for Best Global Advocacy Campaign or National Advocacy Campaigns a couple of years ago. Norwegian Cancer Society started their first campaign on cervical cancer screening in 2016 and carried on each year every September. And they pushed the government to get behind this to increase the number of people who are presented for screening for cervical cancer, particularly in the younger age group, where it's unusual, but nonetheless it can be quite fatal. So they've worked very hard with a number of partners. They've embraced technology. They've reached out to social media to get young bloggers to influence the thinking of that younger age group. They provided better information written in the text that can be understood by that target audience. And working in partnership with the cancer registries, the governments and others, they've actually increased the percentage of that group that actually present for cancer screening. It's a great example. The Nepal Cancer Relief Society, they've been running this since 2011. So quite a long project, but it's about tobacco control. And this is one of the things that I'll talk about very briefly later, is that advocacy on cancer control and implementation takes time. This is not a one-year hit. You've got to plan and execute over many years in order to achieve the objectives that you set out. But as you can see from this slide, they've made great progress in getting improvements in tobacco control, with more warning signs and pictures on cigarette packs, engaging the government, engaging restaurants, engaging hospitals to ban tobacco use. Some of us might find that strange, that hospitals were allowing people to smoke in hospitals, but this is the situation that they found in their country, and they've made great progress. There's another example, Cancer New South Wales in Australia. And now they wanted palliative care to become more prominent in the planning of in their particular state, and they wanted funds to be made available to improve the quality of palliative care and availability of palliative care, particularly to some of the forgotten groups within their community. And as you can see here, they set out a clear objective. They wanted 10 full-time equivalent palliative physicians in place, 129 palliative care nurses, and at the end of their campaign, which ran between 15 and 17, collecting data and then pushing for political decisions, they were able to get pledges from politicians, and eventually the government released $100 million for palliative care over the next 4 years. A great win, addressing one aspect of cancer control, which is critical to that particular part of the world. So let me talk about some final thoughts about what makes for good advocacy. I've called them the 16 Ps. These are just things that help guide me when I'm talking to others about what you need to consider in terms of using advocacy to achieve change in cancer control, cancer treatment and care, whatever it may be. Be clear about purpose, about what you want to achieve up front. There is no point starting something unless you are very clear when you're talking to the people you're advocating with that this is what has to be achieved. Use past analysis to see what's happened in the past and how others have been successful in that space. Map the political space, understand who are the people that you need to influence, and work with the people in power, those who can stop, but also those who can help you achieve your objective. Find great partners, work with others. A single issue with a single organization has less chance than a good issue shared by many others who can spread the word and work with different communities. Understand what the processes of influences are. Yes, there are formal processes when dealing with the government or with the UN system, but there are also informal processes you need to understand. And be persuasive around the head, the heart, and the pocket. You may need to infect the thinking of the finance minister. They tend to have hearts, but their pockets are more important to them. So understand what the financial implications of what you're asking for and where there's an economic case for action. Do long-term planning. Be a pilot, set up all your data so you know what's happening and how you're being received. Permanently scan for more information and pick a great team to do the project for you. And place that team in the right place. If you need to influence a particular organization, a politician, a government, a UN body, there's no point trying to do it remotely, face-to-face, even COVID times, is really important. Interacting face-to-face at the right meeting at the right time is really important. Be patient, it will go wrong sometimes. Prepare to seize opportunities when they come up and prepare your battler. If you don't get exactly what you want, what would you be prepared to take as a first step in the longer term plan? And don't think it's finished until it's finished. You have to push over the line. Some other final thoughts. Here's some great toolkits that are available on the UIC website. If you want to go there, a lot of what I've said is covered in that. And also the International Cancer Control Partnership Portal has lots of information about advocacy and national cancer control planning. And there are a few events coming up in the next few months. We've got the regional series in North America online on June the 1st. So if anyone wants to join in and meet others in the UIC community talking about issues which are relevant to North America, please put that in your diary, go to our website and sign up. And we are bringing the World Cancer Leaders Summit to Boston, when the world's leaders will either be dialing in or attending a meeting which is looking at how innovation can advance cancer control equitably, and within that, probably how innovation can impact advocacy and achieving what we all want to achieve in cancer control at a national level. Well, I say thank you for the opportunity to talk to you today. I hope that was useful. There's a lot to be done in cancer control globally. If any of you are interested in helping or supporting UIC and its members around the world, please contact me. We'd be delighted to talk. Thank you.
Hello, everyone. I'm Antonella Cardone, the director at ECPC, the European Cancer Patient Coalition. And today I will speak about what is health technology assessment and why patients should be involved in HTA. So who we are the largest European cancer patient umbrella organization. We were founded in 2003, and since then we have developed a membership of over 450 organizations from 47 countries globally. So we cover the whole of Europe, and we have at least one member per each continent. We advocate for patients to be acknowledged as equal partners and co-creator of their own health. And we work for a Europe of equality, where all Europeans with cancer have timely and affordable access to the best treatment and care available throughout their life, no matter where they were born or live. Since June 2019, we have a new strategy, and the new strategy is based on 5 pillars, including policy, research, education and capacity building, communication and governance. On the policy side, we work at the European level to make sure that the major priorities for cancer patients are addressed in the policy arena, that is with the European Commission and the European Parliament. And we also make sure that our members at country level can be empowered through the policy work that we do in Brussels. We work on research, and we are involved on the largest EU-funded research projects, and we make sure that the patient voice is heard on any research project. On education and capacity building, we work on empowering cancer patients so that they can advocate for themselves. And on communication, we run several social media campaigns on raising awareness on different challenges that cancer patients face. And on the governance side, we make sure that our organization is sustainable and based on democratic principles. So on EU-funded projects, we bring the patient voice. And here on this slide, you see a list of projects on which we are involved. Normally, on EU-funded projects, we work on dissemination and communication. We also work on ethical issues and making sure that the patient voice is heard throughout the design, implementation, and monitoring of the project. In terms of advocacy, since 2014 up to 2019 and 2020, we have worked on a number of issues, including the immuno-oncology policy action framework, the European Cancer Patients Bill of Rights, and many more white papers or very high-level topics, including HTA, Health Technology Assessment. Specifically on HTA, we have worked on the response to the European Commission consultation in 2017 on the HTA cooperation. We have also worked on the European Parliament ENVI committee to support them adopting the compromise amendments on EU Commission's proposal on HTA. And we have also worked on several position papers on HTA. Strategically, we have developed and strengthened a number of alliances. Here on this slide, you can see the names of all the organizations and institutions at European level with which we cooperate through a formal agreement or a memorandum of understanding. And those important organizations include scientific societies, include medical societies, other patient organizations, and European institutions such as the European Commission and the European Medicines Agency. So focusing now on HTA, what is one of the major problems that we face in Europe, and it is increasing disparities across Europe? That is the fact that there is no equal access to treatments, to cancer treatments across Europe. For instance, patients in Northern and Western Europe access new products on average 100 to 200 days after market authorization. Patients in Southern and Eastern Europe access new products only 600 to 1,000 days after market access. These delays can cause the increase of the disease, but also can cause the death of a cancer patient. So also in Europe, depending on how the health system is organized, if at national level or at regional level, there can be huge disparities across the same country in between different regions. So when it comes to time to access new treatments. So what is HTA? HTA stands for Health Technology Assessment. So the Health Technology Assessment is a research-based tool to support policy decision-making in healthcare. It can include medicines, medical devices and diagnostic tools, surgical procedures, measures for disease prevention, diagnosis or treatment. And it is a multidisciplinary process to evaluate social, economic, organizational, ethical issues of a health intervention or health technology. In Europe, there are 50 HTA agencies. And this is in Europe what creates one of the biggest problems. So it is fundamental to reduce differences between national HTA approaches with regards to the procedures and methodologies, and make it easier for national HTA bodies to share results. And we do understand that a full HTA harmonization may be difficult to reach because of the non-clinical domains of HTA core model are context specific. However, we do believe that this is the most ideal case scenario. The disparities in the health technology assessment are mainly due to discrepancy within the domains and specifically within the non-clinical domains. So the full HTA process goes through 9 domains, 4 of which are clinical domains and the others are non-clinical domains, including cost and economic evaluation, ethical analysis, organizational, social, and legal aspects. So scientifically based, multidisciplinary means of informing decision-making, and HTA assesses the added value, so the relative effectiveness of a given health technology over existing ones. So it is also a tool to support universal health coverage. So where can patients provide input throughout the HTA full process? So definitely patients can identify their own needs, so they can be used within the process to assess their needs. They can support the identification of the impact of the HTA on quality of life or on the overall survival of a cancer patient in this specific issue. They can also support the identification of the relevance of clinical outcomes, the convenience of treatment, and the patient's autonomy and dignity. They can be involved in the economic evaluation through the cost of the QALY, the qualitative adjusted life years, and they can provide inputs on the logistics, so on the organizational issues related with HTA. So for instance, if a treatment is provided close enough to where the patient lives, or how it is provided or implemented. Then patients can be instrumental to identify ethical and legal issues, as we believe that the patient centricity should be implemented throughout the process and considered throughout the HTA process. So why is the involvement of patients in HTA so important? First of all, because all patients are directly affected by the HTA decision. And in fact, the outcome of an HTA process could result in delayed access to a new treatment or limited access to a certain population. For example, patients that have not previously had any other treatment, or no access if new treatment is not approved for reimbursement. So the information and the insight that patients can provide about the impact of their condition and treatments on their lives is important, because it can't usually be obtained from anywhere else. So only the patient and the patients are the best advocate for themselves if properly empowered. So why is the involvement of patient in HTA, in the HTA process is so important? So there are some challenges and opportunities that we need to consider. When it comes to the challenges, there is a lack of meaningful pathways for patients to participate in HTA. There is no legal mechanism of patients' involvement. There is no HTA harmonization across most European health systems. But then on the opportunity side, there is the opportunity to create a separate European HTA body to interact with the EMA, European Medical Agency. There is the opportunity to harmonize research procedures. There is the opportunity to clear guidelines for health economic evaluations. So this is the main work that we have been doing as ECPC on HTA. We have worked on the Council resumed the work on the HTA proposal under the Finnish presidency in Europe. And at the same time we worked on this policy work, we have also developed and published an e-learning module on HTA aiming at equipping cancer patients on how relevant it is for them to be involved in the HTA process. And so this e-learning module is a motivational tool for cancer patients to be involved in the HTA process. In 2020, we have organized a number of workshops for our members in Greece, Poland, Spain, and Portugal. And we hope to organize more of these workshops in the coming years. We are also working now on a white paper on social disparities across Europe. So the e-learning module that we have launched in 2019 is now available in 6 languages, including English, Greek, Italian, Polish, Spanish, and Portuguese. The last work that we did on HTA was the implementation of a toolkit that is a very practical tool. It is a sort of step-by-step guide for cancer patients to be involved in the HTA process. So this toolkit provides very detailed, very strict details on what cancer patients need to do and which people they need to contact or institutions they need to contact in order to be part of the HTA process. So the toolkit is country-based, and we have started with 2 countries, Spain and Portugal. So those 2 toolkits are now available on our website. Thank you.
So please allow me to add my welcome to today's webinar. We've just heard 2 presentations that lay a great groundwork as a basis for our discussion on patient advocacy today. Please also allow me to welcome to today's webinar, joining Dr. Adams and Ms. Cardone, our 3 additional distinguished panelists, Dr. Takayuki Atsumi, Dr. Kenichi Oi, and Dr. Eduardo Kazap. If each of you could please briefly introduce yourself and tell us in a sentence or 2 why it is that you find yourself on a panel discussing patient engagement in policy decision making. Let's start with Dr. Atsumi. Dr. Atsumi.
Hi. Yes. Thank you very much for inviting us to this panel discussion from Japan. My name is Takayuki Atsumi. I am the representative of the Cancer Support Community Japan, affiliate of the Cancer Support Community in the United States. Headquarters is located in Washington, as you know. And I used to be a surgeon, but now working in the hospital. as a endoscopist or other. So
thank you very much. And Dr. Oe, tell us about yourself.
Yes. My name is Kenichi Oi. I am doctor of dental surgery. My specialty is oral cancer, and I'm a program director of Cancer Support Committee Japan. Cancer has been the leading cancer of death in Japan since 1981. In 2019, the number of the deaths due to cancer in Japan is highest for lung, colorectal, stomach, pancreatic, and liver cancer. Effective interactives are available for most of their high band cancers at various stages of the cancer control, including cancer prevention, cancer care, palliative care, and survivorship. However, I think that all request effective partnership multi-stakeholder beyond the healthcare sector. I am participant in this meeting companies because I want to get various cancer control information at this meeting. Thank you.
Thank you very much. And Dr. Kazaf.
Thank you very much for your kind invitation, Dr. Carlson. I am Eduardo Casab, a medical oncologist based in Buenos Aires, Argentina, president of the Latin American and Caribbean Society of Medical Oncology, SLACOM, and past president of the UICC. In the last 20 years, my main interest is global cancer control and public policy to benefit patients and healthcare systems around the world. Thank you very much.
And thank you all. So Dr. Kazap, let's start our discussion with you. We just watched these two very impressive presentations on the importance of patient advocacy efforts in policy decision-making in areas such as cancer control planning and health technology assessment. You've dedicated, as you've outlined, most of your career to advancing global cancer control and prevention. In your experience, what lessons have you learned? What are the best strategies to collaborate with patients and patient advocacy groups in policy engagement and advocacy? And because of your sort of unique perspective in these initiatives, talk with us about the global perspective, but also the implications and perspective on your local Latin American region as well.
Yes, Dr. Carlson, thank you for your question. Well, I think that we need to analyze this in an helicopter vision. This is a problem that covers all over the world. And for that reason, I am not very keen with the concept of really low and middle income countries. This is not a question of economies only. This is a question of cancer development and integration. So you have pockets of really very low, very extremely low cancer control efforts, also in Europe, in the US, and in many parts of the world, regardless of the economic situation of the country. You can have the best care and many other things for cancer patients and for people in larger cities of Brazil or Buenos Aires or Mexico. But that is not the situation. The current measures for better cancer control covers less than 20% of the world population. So let's analyze the process in the last, let's say, as Dr. Adams said, 2010, 2008, 10, 12 years. The question at that time was to put cancer in the global agenda. But now, 12 years later, we have cancer in the global agenda approved by the most relevant international organizations, such that graphic that Dr. Adams showed to us with the increase of international actions covering really most of the aspects of best and better cancer control. But what happens now? The reality is quite different. Analyzing the outcomes since the first UN declaration for NCDs in 2011, the results are poor. The results are very poor. So we have now the question of implementation of real and concrete actions at the local level, because we have an umbrella of many declarations, plans, recommendations. In Europe, you have, as an example, the European Cancer Code, and actually that recommendation for patients in Europe was not as successful as what it was originally planned. We are trying to develop now with PAHO and EARC, the Latin American Cancer Code. So I think, and please tell me when I need to finish because I don't go, but I think that my idea is to frame this situation. We need to talk about not only patients, we need to talk about citizens for prevention because they are not sick yet. We need to speak about patients and we need to speak about survivors. And I think that for this, we have a very nice example developed by our common friend, Ben Anderson, about the virtuous cycle of patient in cancer control. That means a cancer patient, a diagnosis, adequate and early diagnosis, correct and timely treatment, and then you have a survivor or a patient that will integrate a patient organization that will promote at the government and policy level for better care and better prevention and so on, enriching the cycle. For this, we need that patients act as stakeholders. The passive participation of patients during my last, 40 or 50 years acting in cancer as a doctor and just recently, the last 20 years in policy. Patients may be part of the process. And that is something fundamental for healthcare systems. We need to promote patient-centered, as it was described by Dr. Gardo, patient-centered healthcare system. And we need also to use the new tool of personalized medicine to define personalized healthcare systems. So patients' organizations should be included at all levels of the country control process. And my last comment is that which is the real map today of cancer organizations worldwide, highly variable. We did a study for the American Cancer Society many years ago about patient organizations in Latin America. We tested some countries and a couple of conclusions. One, the strongest organizations for patients advocacy in our region were the pediatric cancer organizations. A second observation was that most of the cancer organizations, except the breast cancer organizations, were weak, no professional, and without clear messages to disseminate adapted to the local conditions. That means that ladies asking for mammography when mammography was not available for all the ladies. In conclusion, I think that we need to start a new stage of a top-down, bottom-up strategy. We have the top-down framework. We need to develop the bottom-up strategy from the local communities and countries following the directions proposed by the international organizations. Thank you.
Thank you, Eduardo. Dr. Atsumi and Dr. Oi, the cancer support community, Japan, is actively involved in discussions on the promotion of the Tokyo Cancer Control Promotion Plan. Can you describe for us the role of the Cancer Support Community Japan and other advocacy groups within the implementation of the Tokyo Cancer Control Promotion Plan? You were on mute.
I want to speak Cancer Control Act. In Japan, in 2006, the Cancer Control Act was enacted, and law has been implemented since 2007. Based on this law, the Tokyo Basic Plan to promote cancer control programs was discussed by the first time the Tokyo Cancer Control Promote Council and started in 2008. I have been a member of the Tokyo Cancer Control Promote Council since 2009 and have participated in discussion on cancer control in Tokyo. And now, based on the two-term Tokyo-based plan to promote cancer control programs approved by the Tokyo Metropolitan Government in 2018. Further measures are taken for cancer control based on the three policies of cancer prevention, improvement of cancer care, and living with cancer. 3 points. Especially, we provide professional lead-free psychosocial support for people impacted by cancer. One, the role of advocacy organizations such as the Cancer Support Committee Japan contributes to improvement patient access to medical care. For example, the following case, in 2016, the Cancer Support Committee Japan established the National Conference for Nuclear Medicine Therapeutics. Those are multi-partnership with Japan Society of Nuclear Medicine, the Japan Radioisotope Association, and the Pancreatic Cancer Action Network Japan. Pancreatic Action Network Japan is another advocacy organizations, patient group from 2017. A study group on proper use of radiation was set up in the Ministry of Health, Labor and Welfare. And discussions were held about radiation regulation. Then, in 2019, the medical law enforcement regulations were partially amended to deregulate radiation. As a result, patient access to nuclear medicine therapeutics has improved. Thank you.
Thank you.
Yeah. Do you have a time to short comment of me? Yeah.
Of course.
Yeah. Since 1961 in Japan, as a part of Social Security, all people living in Japan have to take out state-managed health insurance. So anyone can go to the hospital of their choice at any time. So thanks to the system, the Health Insurance Association assist and supplement the high medical expenses of these patients after exceeding about $900 a month. The Health Insurance Association will pay the excess, and the patient self-pay will not increase. So I'm not familiar with medical care system in foreign countries, but in Japan, as long as medical care is the same, a payment for the hospital is unified, and it doesn't vary from hospital to hospital. So the nuclear treatment includes them. Thank you.
And thank you. It's interesting the contrasts across different countries and their healthcare systems. Ms. Cardone, thank you for a great presentation, first of all, on patient engagement with health technology assessment agencies. If a patient or a patient advocate wants to begin engaging with their local health technology assessment agency, when and where, excuse me, when and where is the best place to start their engagement or advocacy? And a second question, do you plan on expanding your health technology assessment toolkit to cover additional countries or regions in Europe?
Thanks for the question. Well, to get more involved in the HTA process, cancer patients and patient organizations are recommended by us to approach the HTA agency in the region or country to ask to be involved. So nobody will call them to be involved. So they have to make the first move. They need to provide their availability. So they need to request to be invited during the assessment process and then respond to the invitation to participate in the HTA activities. They needed to engage in HTA forums and meet frequently with staff from the HTA agency. They try to have a representative from the organization to participate in one of the HTA national or regional committees. They needed to be a member of the hearing boards at any local hospital. And of course, they needed to advocate for the legal regulation of patient involvement. We encourage our members to make sure that the HTA agencies in their countries are legally binded to invite cancer patients to be part of the process. The HTA process should not be based on a voluntary goodwill. And of course, we also invite our members to contact other patient organizations that are experienced in engaging with the agency's work and unite forces. So as per your second question on expanding the countries in which the toolkit will be available, we are planning to work with at least 2 other countries in Europe. Now we are exploring the interest and the need of expanding the toolkit with our members, and are looking into Germany and possibly Romania. We have not decided, we're not made a final decision yet.
Thank you. Question for Dr. Adams. You provided a great overview of the ways that the UICC has established a global framework to allow national advocacy to actually take place. Can you highlight as an example specific cancer control implementation and patient engagement strategies for the sub-Saharan Africa region?
Yeah, of course, I'd like to do that. First of all, just to say that as with all advocacy, as explained by others already, it's clearly important to understand what the problem is you're trying to solve. And on a review of the African countries, sub-Saharan Africa, only a couple of years ago, UICC working with AORTIC produced a rather important document which said what is the state of play across that region with regard to the important umbrella of having a national cancer control plan. And in that context, having cancer registries. Now, to some extent, I know that sometimes feels a bit awkward for a patient group which has a very specific interest in pediatric cancer or in breast cancer, or whatever it is. And there's a tendency for those groups to push very hard for the solutions for their own patients, people who've had their disease. But the context is important, as a global context is, and therefore you really need to make sure that a government embraces the idea of cancer control, which is both prevention, early detection, treatment, and care, in order to have a long-term sustainable commitment from the government rather than a one-off short-term commitment to a specific disease. So that's something I'd like to put up front. If you look across Africa at the moment, you've got about 50% of countries have got a national cancer control plan. And the quality of those, UIC assesses that with the International Cancer Control Partnership, which Dr. Eduardo Gazap helped set up many years ago, is about, we score it around about 35 out of 100. And where the weaknesses are on those plans that exist is the question of whether they're being implemented and followed through, they're measurable, and also whether they're funded fully. So given the scale of the problem that we're looking across Africa, what are the solutions? Well, a solution which I think is important is being clear about the objective and then working with the right people, both formally and informally, to influence the thinking of the government. So the groundwork which a patient group needs to do is to ask questions like, who do we need to influence formally through the process of a national cancer control review, plan review, and informally by working with local opposition leaders or with current government leaders, depending on where the political landscape is, in order to get your ambassadors in the government space to become those that press for a national cancer control plan. A little complication is that they tend to think around NCD plans now, non-communicable disease plans, rather than just national cancer control plans, because again, that's been driven by the NCD agenda globally, but nonetheless, it doesn't matter. As long as you have the content in there for an effective way to address cancer control, then that's fine. The second thing which I think patient organizations, the more successful ones, do is they embrace getting a community together to argue for change rather than working on their own. So the emergence of national NCD alliances, for example, at national level across sub-Saharan Africa has been very impressive. They are somewhat, as hinted earlier, they are somewhat short of resource and funding, but nonetheless, they are very effective at making the case at a national level to bring national cancer control plans and NCD plans together. So working collectively on an argument, I think, has been quite powerful. So there is certainly in Africa major issues with national cancer control planning and registries, often work on hospital-based registries rather than population-based. There is greater cohesion across the patient groups in order to get change to happen. It varies country by country. I wouldn't say that I'd say there's any standout country at the moment, but there's certainly a lot of progress in bringing patients together to get involved in national cancer control plans. So I just was 1 more minute, Bob, just one more thing. The WHO guidelines to countries and also the UIC guidelines and the International Cancer Control Partnership guidelines are no national cancer control plan should be written without the engagement of patients. It should not be written. In fact, it's broader than that. It should be patients and also those working in the health system. So oncologists should be involved. It should behavioral scientists should be involved. People should be involved who are working on the ground. So whenever a government decides they want to put a new plan in place and they reach out to ICCP or through IC or WHO, then they will be pushed and pressed to make sure there is patient engagement. We can't force it. At the end of the day, the government and the culture of the country will determine to what extent they want to engage their citizens in the process of a plan. But what we have seen over the last 10 years is greater engagement. So things are moving in the right direction. Eduardo is less patient than me. He'd like it to be all done really quickly, but it's moving in the right direction. So I'm optimistic that plans will improve and the implementation will improve over time.
Excellent. Yeah, we at NCCN have been engaged with our colleagues in sub-Saharan Africa over the last few years, and one has to be impressed with the resource limitations and the lack of capacity for effective cancer care. But we're also, the complement of that is we're totally impressed and awed by and inspired by the dedication of the cancer care system people that do exist in sub-Saharan Africa. So it's not a lack of smarts, it's not a lack of knowledge, it's not a lack of commitment, it's just a a place where the resource limitations are really quite profound. So thank you for all you're doing to assist with healthcare in Africa. Let's go back to Dr. Atsumi and Dr. Oe. We've all been affected profoundly in the last year and a half by the COVID-19 pandemic. And I think that there's really probably no country in the world that is not touched by it in some way. And those that haven't been touched, weren't touched for a long time, have caught up with the rest of the world. And those that were leading in the epidemic or pandemic, now many of the countries have pretty reasonable control of the infections. But can you describe for us how the COVID-19 pandemic has impacted cancer care and the services that you're able to provide in Japan?
Yes, thank you. Due to the COVID-19 epidemic, it is said that the number of people who have undergone cancer screening and general screening in Japan in 2020 was half to 2/3 compared to the previous year. And the clinic I helped on Saturday as an endoscopist. The number of tests also last year was 2/3 that of previous years. Especially from March to June of last year, various medical academic societies recommended the screening business has be stopped. So worried because of worried about that the screening site might become a place to spread COVID-19 infection. As a result, it fell to 5% in last May. So it is believed that the reduction in the number of people undergoing cancer screening in 2020 delayed the detection of at least 10,000 people with cancer in Japan. And there is a concern that the early stage cancer may have progressed while the detection was delayed. And the treatment method that could have been selected for early stage cancer has become unavailable. In view of the COVID-19 epidemic, the Japanese government also called on the people to refrain from going out unnecessarily. In Japan as well, also many elderly persons are too afraid of getting infection by COVID-19 and refrain from any place, include hospital. As a result, there are many patients whose condition has worsened because they missed the proper treatment. But by yesterday, the day before yesterday, the total of 730,000 people in Japan has been confirmed infection with COVID-19, and the total this is 12,000 people have died in Japan totally. More than 90% of those who died were over 70 years old, and about half of this who are bedridden before being infected with COVID-19. So the number of infected people per 10,000 population in Japan is 574, which is 1/20th that of the United States and 1/10th of the United Kingdom. And I think not too many, but not okay. So one thing, the number of hospital visits, not only cancer diagnosis and treatment, but other common illness has also decreased significantly. The cause of a lot of hospital and clinic struggle financially. More than 5% of hospital and clinic responded that the number of outpatient decreased compared to the previous years. By seeing the data, some doctors say it has proven that there had been many unnecessary and non-urgent hospital visits before. In Japan, some elderly come to outpatient department in order to seek to place for social gathering because of low medical expenses. Thank you.
No additional information. Thank you.
Okay. Ms. Cardone, recently your organization, the European Cancer Patient Coalition, led a joint letter on COVID-19 and cancer, and NCCN and the UICC were among over 300 global oncology signatories on that letter. Can you discuss what that letter was about and describe the advocacy and policy engagement efforts that surround that joint letter?
Sure. So, well, we all know that coronavirus has brought suffering to all health systems, but especially it has had a profound impact on people previously affected by other diseases, particularly cancer. So it has consequently caused serious problems in late diagnosis and treatment of current and future cancer patients, disrupting cancer screening and delaying or altering cancer treatment. So this global campaign that we ran on the joint letter on COVID-19 and cancer united multiple stakeholders to call on governments to ensure that patients can access diagnosis and treatment safely, to identify the impact of the pandemic on cancer services and design services to mitigate this, and to resource cancer services properly and safely for the long term. So we called on governments to state, I am committed and I will invest in prevention, early diagnosis and treatment of cancer. We have started the campaign in March and launched it openly and globally in April. And within a few weeks, we raised over 320 signatures from all over the world to support this statement. We have sent the letter with all the 320 signatures to all the governments in Europe and several governments and institutions globally. We have copied the signatories in the different countries related to the governments that received the letter, so that the signatories could follow up on the letter. And we have started to receive feedback from a few of these institutions, including WHO and some member states representations in Brussels. So we are now following up and setting up meetings, trying also to keep up the momentum with all the signatories.
Wonderful. Next question is both directed at Dr. Kazap and Dr. Adams. How has COVID-19 impacted government support for cancer control implementation? And what actions can patient groups and other stakeholders take to continue to advocate for the importance of cancer control services within their respective regions and countries in the context of the COVID-19 pandemic? And let's start with Dr. Kazap.
Yes, Dr. Carson. We have a profound concern about this matter, and for that we need data. We need data to really plan the post-pandemic stage. Recently, in May 17, we published in the Journal of Global Oncology data about the pandemic and post-pandemic situation in 9 countries of our region. Basically, screening was diminished in around 80% in most of the countries, mainly colorectal, breast, cervical cancer. The delays were not so relevant in radiotherapy treatments or chemotherapy treatments because several governments really keep the continuity of cancer care more or less acceptable. But in general, our conclusion is that according to the loss of screening during the approximately 2 years that we are really having this pandemic situation, cancer care will be affected severely due to more advanced cases and less curability in the next years. And that is something that we are trying to push over the governments, the governments with 2 or 3 really key proposals. One, to keep the healthcare system ready, not only for COVID, but also for NCDs and other chronic diseases. Second, to strategize for resilient health systems and in a way that they will prepare for the tsunami of patients that will come after the pandemic due to the delays that we have. So that is something that we recommend. Please provide data about the impact of the COVID to better plan actions for the post-COVID situation.
Dr. Adams.
Thank you. I support everything that Antonella and Eduardo have said, but perhaps I can provide a slightly different perspective on it. Data is absolutely critical as the foundation of great advocacy post-COVID. So yes, anecdotally, we know many countries have cancelled screenings. There's been delays in operations, chemotherapy, availability of medicines. Some of it because people have been fearful about going in to the hospital environment. Others because they haven't been able to leave their home or travel to. There's a whole series of reasons, country by country. And we're not out of COVID yet. So there's going to be a need for a cancer catch-up in many respects. So what may be good that's come out of this, and I'm trying to look at a silver lining in this dark cloud, because as Dr. Eduardo Casat said, there are going to be thousands, if not millions of people who will be presenting later than they should have been, and the health systems are stressed and tired, and they're going to have to try and deal with that enormous backlog that's going to come through, unfortunately. But the silver lining in the dark cloud is that we have been arguing globally and national level for many years that health is an economic issue. Health is a head of government issue. It's not just about the health department of a government. It's actually broader than that, and it needs a whole of government approach to address the full continuum of cancer control, from tobacco control, where you need the finance ministry involved to increase taxes. That's not the remit of a health minister normally. Where you do need education, and that's through the education secretary. Where you need to address, the involvement, engagement of tobacco in industry discussions, and you have to look at where the investment priorities are. Over and above HTA assessment, the investment priorities are with regard to the burden of disease in a country and what type of hospitals, what sort of training needs to be invested over a 7-8 year period to make sure you have enough oncologists coming through the system to be ready for the growth in years to come. I think that what may come out of the COVID crisis is a recognition at national government level that health is an investment. It has economic consequences if you get it right, and it has economic consequences if you get it wrong. So I would encourage patient groups who are looking at the catch up, and yes, there's an argument to make sure that cancer is included in the recovery plans that most governments are preparing to recover from the COVID situation. But they use that as an opportunity to establish national cancer control as being a head of state issue, and a whole of government issue, and a whole of society issue. And I think the door for that opportunity has never been wider. So that would be my silver lining under a dark cloud. But I agree exactly what Antonella and Eduardo are saying. We must push to make sure that cancer catch-up is part of that recovery plan from COVID.
So we have just a couple minutes remaining in our time. So 1 or 2 sentence answer, short, sweet. How can patients increase their influence and engagement when governments establish policy priorities so that we can assure access to high quality cancer care services? Just 1 or 2 sentences. What are the most important things that patients can do to engage in that process? And let's start with Ms. Cardone.
Well, cancer patients, as any other citizens of the world, do and have a voice, and we want to be heard and speak up, so that policies are patient-centered and tailored to our needs. So the most impactful way to be heard by policymakers is to be informed, educated, and empowered to sit at the table with policymakers and regulators, and of course, to stay united. As together we are stronger.
Wonderful. Eduardo.
Yes, one quick comment. For many patient organizations all over the world, I think that the priority number 1 is to be more professionalized. To be professional, to develop really proper vision papers, and to develop strategies to reach stakeholders and governments to improve the situation of cancer control.
And Dr. Atsumi and Holly.
Yes, anyone can be infected with COVID-19. I'm afraid that I might have been infected. Similarly, anyone can be had with cancer. Anyone is afraid that one might have with cancer. However, they will never be alone because we are discussing like this. We want to believe so. Thank you.
Have we lost Robert? I think we may have lost Robert. Shall I carry on, Katie, with my last remarks?
Yes, please, Dr. Adams, if you don't mind.
Yeah, so I think we have to recognize there are a lot of cancer patients who actually just want to survive cancer and never have anything to do with advocacy or anything to do with cancer ever again. Let's be fair. So I think we need to be clear that it's not in everyone's ambition as a cancer survivor to become an advocate. But those who do want to become an advocate, I think the important thing is that they join a coalition and they work together with others. It's very difficult for individuals or small groups to have an impact on a government. So I would look around in my country and identify who the cancer organizations are who are operating the space, and then to join them and reflect on how you can support those that are actually already campaigning and bring your energy, your enthusiasm to that organization. There are examples in the last 10 years of new organizations starting from scratch, from a patient base, that have done very well in some of the low and middle income countries. But generally, bear in mind this is a broad base that we're talking to. If you're in a country, one, find out who are the cancer organizations in your country active in advocacy, and secondly, how can you help them through your own skills, your own network, your own energy to make a difference. So I would find friends and make a difference.
Wonderful, and I'm back after being kicked off the internet there temporarily. Carrie Adams, Antonella Cardone, Eduardo Kazap, Takayuki Itsumi, Kenichi Oi, thank you so much for sharing your time and your expertise with us today. Totally engaging discussion. I wish we could continue for longer. We do have a couple questions that came in that we haven't had time to get to, but thank you again so much for participating. And with that, back over to Katie.
Thanks so much, everyone. It is really my pleasure to wrap up this wonderful webinar series. A sincere thank you to everyone who have joined today, as well as all of our previous sessions. I would like to also thank Dr. Carlson, our moderator, and especially our exceptional speakers for really sharing their expertise and insights on these important topics. I would also like to thank all of our supporters of the webinar series. Again, without your support, today would not have been possible. It's really a team effort to host these webinars. So a huge thank you to the entire NCCN staff, especially Lee Gallo, Mike Abrams, and Mark Geisler for all their hard work behind the scenes to make these webinars a success. And then lastly, if you missed any of the previous webinars in the series, they will be posted on nccn.org very shortly. So take note of that link and please check back, and hopefully you can access some of those previous recordings if you didn't have an opportunity. Thank you again, and please continue to stay safe. Bye.